Good morning. Topic for today's discussion is various reasons for failures in FPD and its management. This topic we'll be covering in two parts. Today we will be discussing about the biomechanical failure and the mechanical failure. The biological failure we will discuss in the second part. The content of the presentation is listed in this list. Okay. To begin with, the fixed dental processes, what it is actually an artificial replacement of one or more teeth or even the entire dentition that is permanently attached to the patient's mouth and cannot be removed by patient for any other reason or for hygiene. And you all know that this fixed partial denture, it has different components. That is your pontic, your retainer, and the connector. So first of all, the failure can happen with any one of these, either the pontic or the retainer or the connector or on the abutment on which the your fixed partial denture is cemented. And also the failure can result in the cement which you are going to use, okay, for cementing your prosthesis. So what are the objectives of fixed prosthodontic treatment? It provide comfortable treatment to the patient in terms of aesthetics, mastication, and phonetics, and preservation of hard and soft tissue integrity, especially in cases when you are doing your full mouth rehabilitation with the help of your fixed partial dentures. That is to maintain the status of muscles of mastication, to manage the temporomandibular joint. Okay, so this is the main objectives of providing a fixed partial denture. Coming to the diagnosis and treatment planning, I will not discuss this in detail, but the thorough diagnosis and treatment planning is required, okay, to prevent any failure of your fixed partial denture. That is, you have to evaluate the periodontal status, your plaque control, if any flap surgeries are required, or if any flap surgeries are done, what is the outcome of those flap surgeries? And restorative dentistry, what is the existing type of restoration, the type and the age of the processes, if any processes is present, what is the current status of the processes as well as your abutments. Then endodontic evaluation, that is to identify the treated teeth, to monitor the periapical health. Okay, and then if everything goes fine, then only you will going to proceed for your fixed partial denture. If any correction has to be done, it has to be done before beginning the procedure. Then if an orthodontic corrections is required, especially in cases, okay, where there is an drifting of the teeth, especially seen in the mandibular posterior teeth, and to evaluate the occlusion, to see any root resorption if the patient has been referred from the Department of Orthodontics after the completion of orthodontic treatment, because many a times we see cases, okay, referred to the department for either the closing of the spaces which is left after the orthodontic treatment, or in cases where there is a congenital missing lateral incisor. So if in case the congenital missing lateral incisor is there, we have two options. First is either we can close the space by migrating the canine to the space of lateral incisor and then shaping the canine in shape of lateral incisor and then shaping the premolar, first premolar in the shape of canine. Or we have second option is that to restore the space of the lateral incisor and to provide either an implant or since the space of the lateral incisor is less, we can give a 3-unit fixed partial denture on both the sides. So these things has to be evaluated first before proceeding to the fixed partial denture. If any space is less, it has to be corrected by the orthodontic treatment, and then only we can proceed with the fixed partial denture, so that when you give your FPD, it will look aesthetically pleasant to the patient. Then we have to see any removal process if the patient is wearing, and what is the success rate or the failure rate of that removal processes. Any surgical treatment is required, like any root piece or any tooth extraction or any compromise tooth which is present in term of the bone loss is there in, or if the deep caries is where the root canal is not indicated. So all those things can be taken care by by doing a surgical, by doing an extraction. If you use these abutment as a part of your fixed partial denture, then the outcome of your fixed partial denture is unpredictable. Then we have to see your radiograph, what if, like past radiograph, if you have like crown on the other side and it has been done around 4 to 5 years back, and if you have an IOPA or an OPG 4 to 5 years back, then you can evaluate what was the prognosis of that particular teeth in the duration of these 5 years. Then we have to evaluate your temporomandibular joint, okay, to see any pain, clicking, loss of vertical dimension, if any vertical dimension has to be restored. So all these things has to be taken care before starting your procedure. So if you follow the proper diagnosis and treatment planning, okay, then the chances of your fixed partial denture failure is very less. Why we are talking about this is because this is also a part of managing your fixed partial denture prior to the giving the restorations. Then occlusal examination, you have to see your initial contact, evaluate your centric relation with maximum intercuspation position, identify the slide from any centric relation to maximum intercuspation and to record the direction and the magnitude of this slide. General alignment, like check for crowding, supraruption, spacing, malocclusion, attrition, abrasion, any tipping or drifting teeth. Okay, these all will affect the restoration or the fixed partial denture which you are going to give. The type of occlusion, this is also very important. Like if suppose the patient is having canine guided occlusion, then you have to be very careful by uh, for giving a crown on canine. Radiographic examination, you have to see the OPG is required, especially in case of full mouth rehabilitation, your IOPAs, and special imaging like CBCT and all, if it is required, if there is a multiple root canal treatment, especially all these things are required, for doing your full mouth rehabilitations. Then diagnostic cast and articulation. What is the importance of diagnostic cast? It records the existing dentition, help detecting any wear, abrasion, and tooth alignment issues, and it is useful for patient education and also deciding the treatment and explaining the treatment to the patient. What is the importance of diagnostic mounting? It will produce the jaw relationship on an articulator to see, okay, if any supraeruption is there or any drifting is there or any intentional root canal is required. Okay, any occlusal scheme correction is required. Okay, so all these things can be seen, okay, with the help of an diagnostic mounting. Importance of articulation, it simulates the jaw movement. If you are mounting your cast on an semi-adjustable articulator, you can see you can simulate the movement and you can see the interferences. You can even you can uh, plan how much amount of the tooth structure is required on which teeth. Even you can see the height of the tooth, and if you can plan for CLP procedures, for build-ups, core build-ups. So all those things can be corrected at this stage where you are diagnosing the cast and articulating it. Then in treatment planning, everything is very important, but two more thing is very important is evaluating the abutment, okay, on which you are going to give your crown or the bridge. Okay, how is the periodontal health? How is your general health of the tooth? Like if any caries is there, okay, what is the if any long span fixed partial denture is there, what is the condition of the bone? Okay, which is in associate with your abutment teeth, where you have to follow the Anti's law, that is guide the selection and number of size of the abutment which is required. Okay, so all these things again are required. Why I'm discussing only these 2 points? Because these sometimes, if you don't follow the Anti's law, the chances of the failure increases. As you all know, the cantilever should be avoided. Okay, cantilever should be given only in few selected cases. Okay, where the length is very less, especially in the anterior teeth. Okay, span is very less. Non-rigid connector, it is indicated in your prior abutment cases. There you cannot give a rigid connector. Okay, because if you give a rigid connector, again there will be harm, or the more amount of the forces will be concentrated onto the prior abutment. So all these things have to be taken consideration to prevent the failure. Still, we follow all these things And before preparing the teeth, you should follow all the principles of tooth preparation. That is the biological tooth preparation, the mechanical and the aesthetics, conservation of tooth structures, avoidance of overcrowding, your margins, your retention form, resistance form, your thickness of the metal, your thickness of the porcelain, your thickness of your zirconia core, and the thickness of your buildups. All these things has to be taken care. Okay, while doing the tooth preparation. But even after taking all the precautions, there are reasons, there are many cases where there is a failure of fixed partial denture. So how we classify these fixed partial denture? There are plenty of classification which is given. Some of these I will discuss. Okay, and more or less it has same uh, type mentioned in all classification, but they have a different way of classifying it. Like in 1920, Tinkers described the reasons for failure of fixed partial denture. Okay. Uh, That is, he divided into six category. First is the faulty and in some cases no attempt to diagnose and do the prognosis. Second is failure of to remove any foci of the infection, like talking about any periodontal infection or periapical infection. Then disregard to the tooth form. That is, you have to follow the desired tooth form or desired tooth preparation. Absence of proper embrasure, interproximal spaces, and faulty occlusion and the articulation. Sorry. Then we have robot classification. In this robot classification, we have cementation failure. We have the mechanical breakdown. Mechanical breakdown can be because of the flexon, can be because of the tearing, then shoulder joint failure, pontic fracture, bonded porcelain failure, gingival irritation or recession, periodontal breakdown, caries or necrosis of the pulp. Then we have Lombardi classification of aesthetic failure. It has a different type. First one is the inharmonious dentofacial ratio, that is shade disharmony, compositional incompatibility, static prosthetics in dynamic mouth, inharmonious strength or weakness of dental composition. Okay, then weak mouth, strong faces, and strong mouth with weak faces. Means these all you all know that the SPA factors. Okay, which plays an important role in your complete denture. Similarly, it play an important role in your fixed partial denture also. You have to decide the size, shape according to the gender. Then intrinsic dental disharmony, that is space allocation error, that is inadequate vertical space allocation, excessive vertical space allocation, excessive horizontal space or allocation, and structural line error like elevated occlusal plane. Occlusal plane drops down posteriorly, asymmetrical occlusal plane. So these all things again they are mentioned in this category. Then unnatural line, that is the third part of this classification, reverse smile line. Okay, your unnatural axial inclination, cuspless posterior teeth, gradation errors, age, sex, personality disharmony. So all these things we will discuss one by one in detail. Okay, and this like one the point I will discuss here is the gradation error. What is gradation? Gradation effect. If you see the space present between the your cheek and the buccal surface of the posterior uh, teeth. So that is also called as a DVR, deficient vestibular review. So all these things point has to be taken into consideration. Okay, because these are actually will lead to the failure. The single eye error, that is vertical deviation, horizontal deviation, or the line conflict, imbalance, that is midline errors, imbalance of direction, artifact error, and diastema errors. But see, everything it is not possible to correct it. Like if we talk about midline, okay, 80% of the cases maxillary midline, the mandibular midline does not coincide. So what midline we have to take into consideration, especially when we are doing a full mouth rehabilitation, we have to decide the what is your maxillary midline, and if the mandibular midline is slightly shifted also, okay, it will not hamper your success and failure of your fixed partial denture. Then next is the Barreto classification, which was given in 1984 in Journal of Prosthetic Dentistry. These classification include biological failure, which includes caries, fractures, generalized periodontal disturbances, your aesthetics, shape, contour, biophysical, that include physical properties and chemical composition of porcelain and metal, and biomechanical, which include faulty design, your improper finish line, rough or sharp surfaces. So this is a different way of classifying the defect. Then John F. Johnson's classified it in 1986. Okay, so this is again biological failures, mechanical failures, aesthetic failures. So coming to the most common, this was the classification of the failures. Now coming to the most common, failures in fixed partial denture and how we can manage it once it has failed. So first we will be discussing about the biological failures. What are biological failures? We have discussed till now. It's caries, pulp degeneration, periodontal breakdown, your occlusal problems, and any perforations. So caries can be because of overextensions of the margins. Okay, your short casting, your open margins. Okay, where there will be an entrapment of food. Your wear of your tooth, a retainer becoming loose. So once the retainer become loose, there will be an entrapment of the food within the retainer, which will lead to the failure. Then pontic forms fill the abrasion where the patient cannot clean that area properly. Again, there will be an accumulation of food leading to the root caries and the caries in the embrasure areas. Then poor oral hygiene and use of wrong type of retainers. As you can see in this graph, the most common cause for biological failure is caries. Okay, the second number is periapical pathology, but mainly is caries. So we have to, how we can rectify it first is how you detect it. You can detect it with help of visual examination. Okay, check for indisclosures around the margin, or you can use an anti caries solution where you can apply the solution and see the change in the color. Then comprehensive probing of the margin, radiograph of the proximal surfaces. Okay, from time to time if you take, you can detect it, and it can be treated or prevented by meticulous oral hygienes. Okay, your fluoride mouthwash, regular brushing techniques, the water flosser, which is nowadays which is most commonly used, your dietary counseling, your restoring the small carious lesions. Okay, if you see initially, okay, you should restore it immediately. Then the pulp generation, okay, this also you can see the degeneration. What will happen if there will be a pulp degeneration followed by a periapical pathology, as you can see in figure. And once there is a periapical pathology, it will lead to the bone resorption around the your root, and ultimately your abutment will become mobile. So what are the etiology? Again, the etiology is your heat generated during the tooth preparation, chemical irritation caused by some dental material or cement, any microorganism which is present, any caries which you have not able to remove it before starting your fixed partial denture, any caries which you have removed but it is again recurred. So that is recurrent caries has been taken place, or any over reduction of the tooth structure. Okay, or if you are not providing a provisional restoration, and if you have left the tooth for a long period of time and that it is very close to the nerve, this will also lead to the nerve degeneration. So all these things will lead to the pulp degeneration, nerve degeneration, and it will lead to the irreversible pulpitis. As you can see here, that see the margins, okay, all the failures you can see in one OPG. You can see the mechanical failure, the cantilever of the fixed partial denture, which has been given in the maxillary arch, okay. Then the bulky pontic area, pontic, and then you have given the crown, okay, retainer where the margins are open. So all, even in the maxillary arch, you can see the periapical pathology. Okay, and the plane of the occlusion also. So all these things, multiple factors lead to the failure of your fixed partial denture. So what is the treatment? Again, the best treatment is to prevent it. If you cannot prevent it, okay, uh, frequent checkup. If that is also not done, then in cases where there is a periapical pathology or pulp degeneration, you can do your endodontic treatment while making an access through the crown. This is indicated especially in cases where there is a long span fixed partial denture. If there is a single crown and it has been served for a long time, you can even remove the crown, do the root canal treatment, and then you can place the crown, new crown. Then periodontal breakdown. This is again because of not maintaining the proper oral hygiene. Okay, there is a plaque accumulation on the borders. Okay, there is a pocket formation, gingival inflammation. This again, all this will lead to the periodontal breakdown. There will be a bone loss, there will be pocket formation. So this can be corrected again. How it can be corrected? You have to. One more thing I like to add here, that if you are using a cements, and if the cement has not been removed from the margins of the crown, it will again lead to the inflammation. And especially if you are using resin cement for a long period and you have not removed it properly, okay, it will cause an inflammation and the patient is not turned back to you within particular period of time. Then again, it will lead to the inflammation of the gingiva, forming the pocket formation, and then subsequently the periodontal tissue loss. So the radio opaque cement mostly we use is there are many cements available, but most commonly used cements which we are using for your metal ceramic or zirconia restoration are the glass ionomer cement. Okay, so again, the treatment is when you have multiple crown in the patient's mouth, proper oral hygiene instructions, scaling and plaque control therapy must be advised from time to time. Okay, then when your you placing the supragingival margin. Okay, if you are changing the restoration and it is failed, then it is next time when you are giving a posterior region, better to give a supragingival finish line. If any flap surgeries or bone augment or any bone grafting is required, you can do it to prevent the or to extend the longevity of the your fixed partial denture. You can see here the periodontal breakdown here. Why there is a periodontal breakdown? Because the your pontic, there is a space between the pontic and the your uh, bone, you know, and the this will lead to the accumulation of the food. And once there is an accumulation of the food, you as you all know that the if any root caries develop, the root caries progress very faster. So in that cases, okay, this will lead to the bone loss. Then supragingival versus subgingival finish line, it can prevent your failure. Okay, this is especially indicated why I have put this chart here, especially indicated where once your fixed partial denture has been failed and if you are replacing it again. So special emphasis should be given where the supragingival margin is indicated, where subgingival margin is indicated, and what are the advantages and what are the disadvantages. So this is required when you are replacing the your fixed partial denture for the second time. It is required definitely when you are planning it, but special emphasis should be given in like in cases if you see that if you have given your subgingival finish line and there the caries is there, or there is any soft tissue inflammation is there, or some pocket formation is there. So in that case, in the posterior region, it is better to shift from the subgingival finish line to the supragingival finish line. Then occlusal problem. Okay, this is again one of the more common problem. Okay, in cases if you are using porcelain fused to metal, metal nowadays hardly any prosthodontics dentists are using. They are mostly using the porcelain fused to metal, or they are using a monolithic zirconia or a layered zirconia. So in that cases, if there is a wearing of the adjacent teeth, definitely there will be a wearing of the crown and bridge also. In that cases there may be an chipping off of your ceramic over the porcelain, or your chipping off your ceramic over your zirconia core. So time to time, how you can, uh, what are the causes of these problems? These issue arises immediately, like soon after the process is placed, and it is because of the improper occlusion. That means if you have left any high points, okay, then there are chances that uh, high points in the centric relation as well as in the eccentric relation, there are chances that there will be a chipping of the of your ceramic. Then occlusal interferences, okay, during the harmonious jaw movement, marginal wrist position at different level causing imbalance, any supraeruption of the opposing teeth due to the lack of occlusal contact, and then in that case, if you have given the fixed partial denture, the more amount of the forces will be directed to that fixed partial denture. In any parafunctional habit like bruxism or clenching, in these cases, you have to give the a night guard, okay, to the patient to prevent the damage, okay, which takes place during the night time. Then delayed problem, it is again with the time, the if the natural dentition there is a wear, definitely there will be a wear of your existing crown and bridge. So what you have to see, you have to see that there is a stable occlusal contact. Any occlusal correction is required time to time. You have to call the patient and do the occlusal corrections. And delayed problem can be because of incompatibility between your porcelain and resin, or incompatibility or porcelain and gold. Nowadays, we don't use either both the restoration. Okay, we are not using porcelain and resin, and we are not using metal and resin, and we are not using metal and gold. Then food impaction caused by plunger cusp, fracturing of the veneering due to faulty occlusal contact, periodontal or gingival damage, okay, which is due to the improper occlusal loading, and tenderness or discomfort from the persisting food dislodgement. So, what is the treatment? Treatment is, as again told, that your regular checkups are required if you have multiple crowns. Then reshaping of the crown is required time to time. Okay. Then corrective treatment therapy should be again given time to time. Night guard can be given in cases where the patient is having a bruxism or clenching. And you have mobility from trauma of the occlusal can be reversible if you have can remove the trauma. Okay, if you can diagnose this and you can. So thank you. This was regarding the failures of fixed partial denture, which we have covered. In the next part, we will be covering about the mechanical failures and the failures in the zirconia crown and bridge.